Hello, good afternoon, ma'am. I'm Dr. Sandhya from YCM.
Good afternoon, Sandhya ma'am. I'm Pratiji. How are you doing today?
We are doing good in YCM.
Okay. So is the patient out of your unit?
Yes, ma'am. It's a patient of my unit.
Okay.
What is Sabha's current career status stage?
Sorry, sir. I'm working as a third year PG resident here, sir, at PCMC, PGI YCM.
For MD?
Yes, sir, for MD.
So your exam going right now?
Yes, sir, I'm exam now.
When are you facing your exams? Sometimes in May or June?
May 19th is the date, sir, that they've given for the theory exams.
Always prepared.
Yes, preparing, sir.
Will be with little inch will be extra. Yeah, expecting.
Actually, I'll just introduce something postgraduate institute to ICM because it's a new. Hello.
Your voice is cracking intermittently.
Okay, am I audible now?
Yes, you're audible. It's intermittently your voice is a bit cracking.
Okay, I'll just go to the window. Okay, am I audible at present? Yeah, basically, this postgraduate institute YCM is basically we had a YCM hospital which has been converted into a postgraduate institute. So at present we have 4 postgraduate MDs. We do not have CPS DCH. This is the first exam going batch which will be appearing with Sabat. We have 3 more: Dr. Abhijit, Dr. Rizwana, and Dr. Komal. So that is in brief. We have huge load of patients. We do have quality cases also. And that's all about our YCM.
So Sabat is going to be having a benchmark, first batch
Yes,
passing out.
So lots of yes.
We will start in 5 minutes. In about 2 minutes, we'll start.
So I just because I've not attended this the Pune PG clinics before. So usually, what is the flow of events? The resident presents first, and at the end we have discussion, or does it go simultaneously? What is the usual flow?
Actually, there is no such format as such. I mean, as we assess the child, assess the student for the history taking, and we see that whether they approach well, and then or anyway, it is just like any other postgraduate teaching case. And at the end, if it's an interesting, I mean, we get a lot of inputs from the expertise, and that's it. Or where we may have gone wrong in the case, and we could have approached it much in a better way, or that's it.
Can we start? Are we live? Hello.
राजेश सर आपण चालू करू शकतो.
I think let us start. And am I audible, Dr. Sandhya?
Yes, you are audible.
Yeah. So
Yes, you are audible.
Can we start? Can we start?
Yes, sir.
Yes, sir. Yes, sir. We can.
Good afternoon, one and all. I'm Dr. Sabahat Ahmed. I'm a third year PG resident here at PGI YCM Hospital. And my mentor for today is Dr. Sandhya Haribhaktan. She's an associate professor here at PGI YCM. Chief complaints. Here's a 2-month-old male child, first by order of birth, born out of non-consanguineous marriage, resident of Shikrapur. Mother, being a reliable informant, came with chief complaints of swelling around the eyes since 7 to 8 days back, vomiting since 7 to 8 days back. History of presenting illness. The mother noticed swelling around the eyes since 7 to 8 days back, which was insidious in onset.
I'm unable to hear you, Dr. Sabahat. Are the others able to hear it?
Sabahat, you are not audible. Hello. Just a minute. I'll check what happened.
Hello, am I audible now? Hello.
Yes, you're audible, Dr. Sabahat.
I'm sorry
You
for
are
the
audible now. Can you start from the first slide,
Great.
Dr. Sabahat?
Yes, sir. Good afternoon, everyone. My chief complaints. Here's a 2-month-old male child, first by order of birth, born out of non-consanguineous marriage, resident of Shikrapur. Mother, being a reliable informant, came with chief complaints of swelling around the eyes since 7 to 8 days back and vomiting since 7 to 8 days back. The mother noticed swelling around the eyes since 7 to 8 days back, which was insidious in onset and gradually progressive, and then progressed over 1 week with distension of abdomen and involvement of the lower limbs and upper limbs present throughout the day with no relieving factors. It was associated with decreased urine output, with mother giving history that the child used to pass 8 to 10 times a day and presently passing only 3 to 5 times of urine per day. There was no history suggestive of thin stream of urine. It was not associated with dribbling of urine, and it was not associated with blood-stained diapers. The mother also gives history of vomiting since 7 days, acute in onset, non-forceful, small in quantity, whitish colored, curdy, and was not associated with blood and was non-greenish stain.
Sabahat, you are not audible again. Hello. Sabat, can you hear me?
Has led this technical problem. I'll just look into it.
Hello.
Yeah, Sabat, there seems to be a problem with your internet connection.
Yes, sir. I've. Yes, I'm sorry, sir.
Okay, can you start?
Yes. There was no history of fever, rash, lethargy, or excessive irritability.
Sabat, maybe you can join from somebody else's device. Your voice is not audible. You know, we are losing connection again and again. And I can't see the screen either. The PowerPoint is also not seen.
Hello, sir. My laptop seems to getting disconnected repeatedly, sir, from the internet.
Can you fix it quickly?
Yes, sir.
I'll join. Hello. Hello.
Sir, you are audible.
हा नाही कोणीच काही बोलत नाही आवाजच येत नाही म्हणून काय करावं?
We are just waiting for Sabat to stabilize his internet connection. Can we start, Sabath?
Yes, sir.
You share your screen because I can't see your screen.
Yes, sir.
Prabhat, please disconnect your second device.
I'm sorry, everyone. Sorry for the interruption. Should I start again, sir?
Just a minute. I'll first introduce. So today we have Dr. Anand Deshpande, sir, who is a senior pediatrician. Sir is attached to Dinanath Mangeshkar Hospital and a very keen academician. I think many times sir has blessed us by his presence. And we have Dr. Pratichi Kadam, who is a consultant pediatric nephrologist at Surya. I think Sabath, you can start now.
Yes, sir. Here's a 2-month-old male child, first by birth order, born out of non-consanguineous marriage, resident of Shikrapur. Mother, being a reliable informant, came with chief complaints of swelling over the face since 7 to 8 days back, vomiting since 7 to 8 days back. The mother noticed swelling around the eyes since 7 to 8 days back, which was insidious in onset and gradually progressive, and then progressed over 1 week with distension of abdomen and involvement of the lower limbs and upper limbs, present throughout the day with no relieving factors. It was associated with decreased urine output, mother giving history that the child used to pass 8 to 10 times of urine a day and presently passing 3 to 5 times of urine. There was no history suggestive of thin stream of urine. It was not associated with dribbling of urine. It was not associated with dribbling of urine. It was not associated with blood-stained diapers. The mother also gives history of vomiting since 7 days, since last 7 days, acute in onset, non-forceful, small in quantity, whitish colored, and was not associated with blood and was non-greenish stain without any history of aggravating or relieving factors. There was no history of fever, rash, lethargy, or excessive irritability. There was no history suggestive of suck cycle, excessive perspiration during feeding, increased work of breathing, or increased precordial activity. There was no history of blood transfusion received in the past, and there was no history of hoarse cry, feeding difficulties, lethargy, or constipation. Antenatal history. First trimester, married life was 7 years. First child, non-consanguineous marriage, registered and booked case. Urine pregnancy was positive at 1 month of amenorrhea.
Nick, you can just go back on the chief complaints again once before going to the. So just generalized.
Yes, sir.
Edema or generalized swelling of the body. It was the only complaint. Are you able to hear me?
The complaint was insidious in onset and progressive, sir. It was first started around the eyes and then progressed over the it progressed over a few days of 7 to 8 days. It progressed all over the body and it was a generalized edema on admission, sir.
Okay. And what is that called? Generalized edema is called as what? What is the term used? Anasarca.
Anasarca.
So there is generalized edema. Was the child sick looking or non-sick? Look was
on history.
Or this on
history.
Okay. So what are the likely causes of at 2 months generalized swelling of the, or maybe at birth? You can tell at birth what are the causes of generalized swelling?
At birth, so we'll have to rule out causes of hydrops fetalis, immune and non-immune hydrops fetalis, and some congenital anomalies of kidney, ureter, and bladder can present like that, and congenital nephrotic syndrome also can present with such complaints.
Okay. But this in this child it was not present at birth. It is normal baby at time birth.
Yes, sir.
And started appearing around 1 month.
Started
Around 1 month.
7 days back. The child is 2 months old now. Yeah, around 1.5 months later after birth,
Around
the
1.
child has started all the complaints.
Go ahead.
Yes.
Dr. Sarvat, I wanted to ask something. In your next note, the previous slide, before the
Yes, sir.
IAP history.
Yes, ma'am.
Like, what have you asked all these for? Can you explain why have you asked all these histories? What is the relevance?
Ma'am, I've asked for fever, rash, lethargy, or excessive irritability to rule out any sepsis in the child, which can lead to AKI and cause these complaints.
Okay,
And
so
I've
sepsis for
asked for
AKI. Okay. Then?
yes, ma'am. Sorry. And there was no history suggestive of suppressed subcycle excessive perspiration to rule out any symptoms or signs for congestive cardiac failure, ma'am.
Yes.
Which can also present with such
does
complaints.
Congestive cardiac
Generalized
failure
edema,
present as edema
output.
at this age group? Does congestive
Sorry,
cardiac failure presents as edema in this age group?
Less likely with edema, more of increased precordial activity and
You must have seen
tachypnea.
you must have seen lot of VSDs with failure.
Yes.
Anyone
Yes,
at 3 months or 4 months of age? How many times you have seen edema and generalized edema is a little far. Pedal edema, how many times you have seen?
Yes, they mostly present with like decreased urine output and increased
That is in
tachycardia and
symptoms. In science, what is the sign of failure? There is symptoms. Instead of edema, what they get in infancy? Instead of edema, what they get?
Increased precordial activity and increased work of breathing.
The hepatomegaly is very, very
What
common.
will happen to the liver? Sabha, this has been discussed n number of times.
Hepatomegaly is
edema you don't get,
in
isn't it?
infancy, not edema.
Yes.
Okay. So generally, you won't see any congenital heart disease presenting with the generalized edema or even pedal edema, or if the baby is lying down, sacral edema. That is not seen.
Yes, sir.
Okay.
Okay, sir. Yes,
So what else? Keep continuing now. So why have you asked the other things here?
Ma'am, I have asked for any history of blood transfusions in the past, like the child, if they have these alpha thalassemias, and they would present with edema at birth. I mean, with non-immune hydroxypetal is one of the causes for it is alpha thalassemia, and any cause of feto-maternal hemorrhage.
See now I'm
Can
going to
present
start next.
early.
Yeah, your next slide is antenatal history. So I'm assuming you have finished your history of presenting complaints and history of etiology is already done, right? That means this is the slide for that, right?
Yes, ma'am.
Yeah. So whenever after your cardinal complaints, so your cardinal complaints here are chief complaints here, oliguria and is less decreased urine and there is edema. Okay. So whenever you're going to ask for a negative history, that's very relevant to what your chief complaints are, or what you want to point towards. Okay. Now, host cry, feeding difficulties, you are leading me to a very different direction. If you want to lead me in the right direction of edema, because I'm sure you must have read something about it. So you want to lead me to the right direction of edema and decrease urine output, you have to lead me with your negative history as well. Okay. So whenever you ask for negative history, always classify and categorize in your head, okay, now what I want to ask. So chief complaints are done. Along with the chief complaints, you also have asked the relevant history along with the decrease in output. Is any red urine? Is there any dribbling of urine? So well done. You've asked for that also. Okay. Edema also you've done a good job by asking where it began, how it began. It was around the eyes and it went downwards. You've asked that as well. Now, next part of the history should always be now asking for history of etiology. Then what do you think could be the causes of these things? Okay. In history of etiology, what could be the causes? Just category. always if you categorize your history, you will not miss out any points, and you will not. Now, what are the chances of this child having some bleeding syndrome, or what are the chances? It is part of the differential, but the chances may be slim. No?
Yes, ma'am.
Yeah. So for history of etiology, okay, now causes of edema and oliguria in a 2-month-old child. What could be your causes? Let's talk of the 4-5 causes and then ask the relevant history.
Yes, ma'am.
So what could be the causes?
The renal causes are one of the causes for.
So renal causes
the
is
cause of
very broad. Renal cause is very broad. So you have to kind of put it down. So renal may also you have either infective, or dehydration related, or congenital anomaly related, or some some tumor related. So in renal has so many other small things, right? So just can't say renal. So what in renal? Okay, what can it be in renal?
Infective causes or leading to AKI can lead to
Infective causes. So like UTI, something like a UTI. Okay. Again, it's very rare that will come to use edema. It's very rare, absolutely rare, but fine. You are talking about it. What else?
Congenital nephrotic syndrome is one of the cause for generalized edema within
At
3
this
months
stage.
of birth.
Correct. Is there any history here you can ask about congenital nephrotic syndrome? Anything here you can ask?
Or, in antenatal history, we can. Here.
Yeah, you can ask me. What will you ask?
Antenatal history,
Yes, what will you ask?
we can ask whether she had any anomaly scan which was done and which showed any kidneys on the ANC USG or large placenta on ANC
Large
USG.
placenta. So first thing was wrong. Nothing. Kidneys may seem fine, but large placenta. Yes, there can be a large placenta, almost more than 25% of the fetal weight. Yeah, so that can be there. Okay, so congenital nephrotic. What else can it be? Sometimes certain tumors can also arise in the kidney at early age. Again, rare, but it can. Okay, so did the mother notice any lump in the abdomen? Was the child feeding well, accepting feeds well? Was the child not feeding, lethargic over the past few days? So there's some few things you can ask. Okay. So what else? Then what else besides renal can cause edema? So renal you have taken care of. What else besides renal can cause edema? You said cardiac, but as sir said, cardiac at this age will rarely come as swelling. Okay, it's rare, but it is one of the causes. Again, very rare. Hardly they come with such symptoms. But yeah, okay, fine. What else? Very other common system causing edema.
Any obstruction to the lymphatic flow can cause edema.
Okay, but something very important you're forgetting.
That will be localized. Where do you get a localized edema? Which condition you get a localized edema? You talked about.
Suppose you have a girl who has an edema only on the legs.
Lymphatic.
Lymphatic, yes, sir.
Yeah. So where do you get lymphatic edema?
Which condition you suspect?
Turner syndrome, they can be lymphatic. Turner syndrome, they can be lymphatic obstruction and edema. And any tumors in the chest or chylothorax, which can compress the lymphatic flow and cause
the basics. Dr. Sabha, think of the basics first, because when you put your foot into something like this, we can take you on that trip. So don't put your foot in. Just keep to the basics. So yeah, as I said, Turners can give rise to edema. What about liver conditions?
Liver conditions.
What do you think?
The child will present with icterus, or the child would be sick since birth, and child would have vomiting episodes.
Yeah, the child will be more sick. The child won't be like a happy child. The child will be more sick. The child will have yellowing of sclera. Will have distension of abdomen. It won't come typically first in the eyes. It will come first typically in the belly. There will be distension of the abdomen. And child is typically sick and not a well child. So again, it's a valid history to ask. Again, less likely to be your patient, but it's a very valid history to ask. Okay. So you asked about history of etiology. Next thing you have to always ask is history of complications. Okay. I am dividing this for you because I don't want you to miss out any points. Okay.
Yes,
So
ma'am.
what complications will you have when you have decreased urine output also, and you have swelling also? So what complications are you going to have in a 3-month-old child?
Loss of intravascular volume can lead to shock, and child might present in shock. So that complication is possible in this case, or increased hemoconcentration will be present that could lead to thromboembolism and
Why is the
sequelae
hemoconcentration? Why is the hemoconcentration?
because the intravascular volume is reduced.
Okay,
And
so okay.
yes, ma'am. And also in nephrotic syndrome, there will be loss of antithrombin 3 and protein S, which can lead to coagulation disorders, and
So you
that
have
can lead to
assumed this
thrombosis.
nephrotic syndrome. So we will
I've
think
ruled
of,
out other causes.
yeah. So whenever there's a lot of fluid on board and a lot of fluid in the body, there's edema, there's decreased urine output. Then that can lead to fluid in the other parts of the body also. So there can be fluid in the lungs, can be fluid in the heart. So you have difficulty in breathing. Is there any increased precordial activity? Other thing is this can be hypertension in a 3-month-old. Very commonly we have children who come to us with some CNS symptom, and when we check the blood pressure, it's really high. So you can also ask for any signs of convergent neuro deficit. But again, this doesn't come immediately after chief complaints. Okay, so chief complaints, your etiology, and then your complications come. So always maintain that order. If you ask your convergence right up in the head, you'll get confused. Why is he asking for convergence? So put it a little below in the later part of the history, but it should be in the history of complications. Then again, in nephrotic syndrome, you can have infections, any reddening of the skin anywhere, distension of abdomen, along with is there any pain? Is a baby crying when you're touching the baby's tummy? All these are very valid history points to kind of rule out your diagnosis. Okay. Okay, and now you can go to your, so are you understanding? Always when you categorize your history, right, you don't miss out anything. Okay, so your chief complaints are valid. So pointing to, so you want us to go somewhere, right? You want us to lead to some diagnosis, right? So ask appropriate etiology and ask appropriate complications history. And then the flow is very maintained. Okay, go ahead, go ahead.
Antenatal history. Married life was 7 years. First child, non-consanguineous marriage, registered in a booked case. UPT was positive at 1 month of amenorrhea, and pregnancy was confirmed at 1.5 months by USG. At 3 months, ANC USG revealed swelling over the neck of the fetus, and parents were told to get amniotic fluid examined for various anomalies, which was performed and told to be normal. Calcium and folic acid tablets were started at diagnosis of pregnancy and taken for 3 to 4 months regularly. No history of PV bleeding or spotting, no history of fever or any history of medical illness in the past, no history of excessive vomiting present. Second trimester was uneventful, and third trimester also was uneventful until the 9th month, where USG scan was done and was said to have decreased fetal movements, and hence delivery was advised. Birth and postnatal history. Child was born full term through lower segment cesarean section in view of decreased heart rate and decreased fetal activity. Child cried immediately after birth and was shifted to mother's side. Child was breastfed immediately within 1 hour of birth. Birth weight was 3 kgs. Child was later fed through Vati spoon feeds with formula feeding due to inadequacy of breast milk. Child was admitted at NICU under observation for 2 to 3 days in view of vomiting episodes and was discharged at 5th day of life. And there was uneventful stay at home until the last 7 days. Family history was non-contributory. Developmental history: child has partial neck holding, palmar grasp reflex was present, intermittent hand opening was present, turns head to sound, and child was recognizing mother. Was looking at her face when spoken to. Social smile was there.
Stop. Turn heads to the sound at 2 months.
Yes, sir.
कधीपासून एवढं लोक एवढी हुशार मुलं व्हायला लागली तर कसं काय म्हणलं? Turning head to the sound is not so early. You must be a very advanced child. Turning to the light, I can understand. Turning to the sound is very late. Nobody would have devised this deafness test or a hearing test. If it was so obvious at 2 months, that when we start turning head towards the sound, then there was no need of various tests for the judging deafness. Turning head towards the sound, localizing sound is quite late. And so don't put it there. You may, what you want to say is that with the sound child, there is a change in the behavior of the baby. That can be understood. With some sudden sound, baby may cry or get startle reflex or like that. That is accepted. But turning head to the sound is at 2 months is not there. So palmar grasp is reflex is present. Okay. Child is 8 weeks now already. Okay. When it disappears, palmar grasp. When palmar grasp disappears.
Third month onwards it starts.
Hello. I'm audible. Am I audible?
Third month.
You're not prepared for it.
Hello.
So it starts appearing.
The screen sharing has gone. Something else is shown.
Sabahat, your screen sharing is not there now. Can you go back to the screen share?
Some button has been pressed. Okay, by the time, yes, it is seen. So when the palmar grasp goes, that is a very simple question. Their internet is having gross problem. Hello. Your voice is completely breaking. Your voice is breaking.
Hello. Sabahat, can you hear us?
What is up? One should check one's internet before. Are you able to hear, Sabha?
Can you hear, Sabahat? Can you hear us? Do you want to disconnect and join again, Sabahat? The internet's issue. We can see some G10.
Okay. So for the benefit of others, we can now keep on discussing. The basic rule of the is all these reflexes has to disappear before the voluntary grasp. Grasp reflex has to disappear before the voluntary grasp sets in. So
Am I audible now, sir?
Yes.
So the palmar grasp starts disappearing from 5th month onwards, sir.
Okay.
When does it disappear, Sabahat? When does it go?
5 months.
And what comes after the palmar grasp goes? Why does the primitive reflex disappear?
Immature pincer grasp.
Yeah, so that has to disappear before you get a mature reflex, isn't it?
Yes, sir.
Any reflex has to disappear before the voluntary action sets in. So before rollover, the ATNR has to disappear. Asymmetric tonic neck reflex has to disappear before the rolling over starts. Symmetrical tonic neck reflex has to disappear before crawling or creeping starts.
Yes,
So
sir.
the primitive reflex has to disappear before the voluntary action starts. It is the general rule of development. Okay. What about neck holding? I think we'll take a separate class on this. Let's because this topic itself is very big. So we'll go ahead. Go ahead.
Okay, sir. Diet history: child was being breastfed every 3 hours, eight times a day. Child used to suck well over breast for 15 minutes each time and slept well between feeds. Passed urine 8 to 10 times a day. Socioeconomic history: according to the modified Kupuswamy socioeconomic scale, family falls under the upper lower class with a score of 9. Summary: 2-month-old developmentally normal male infant born out of non-consanguineous marriage with chief complaints of swelling around eyes and gradually progressing to involve the whole body with associated decreased urine output is probably a case of subacute onset generalized edema of early onset renal origin, probably due to congenital malformations of the kidney.
Dr. Sarma, there are a few questions I want to ask you about the history, which I'm not very clear about. Okay, so you have made this provisional diagnosis or summary for us. Okay, so a couple of questions, and you go back to your antenatal history. No? So I'm trying to read out. So very important point you have put out is that amniotic fluid was normal. So there was no polyhydramnios or oligohydramnios at any point of time. Where does this amniotic fluid come from in the mother? You know? What is this amniotic fluid? Are you aware?
Amniotic fluid is mostly comprised of the fetal urine, ma'am.
Correct. So why am I asking for, very good. So why am I asking for, is there any history of polyhydramnios or oligohydramnios? Why am I asking that?
In cases of renal anomalies, they usually present with oligohydramnios.
Yes.
And other causes like esophageal atresias will cause polyhydramnios.
Yeah, so your answer is partly correct, Dr. Sabas. So renal anomalies, if they have the oliguric varieties, some malformations or obstructions, they'll lead to oligohydramnios. But certain renal anomalies, like the tubular disorders or Barters, can also cause polyhydramnios. So much severe that sometimes even they have to remove the amniotic fluid therapeutically. So it's not, so you're right in saying that polyhydramnios is commonly seen in esophageal atresias and things like that, where the baby cannot swallow, but not necessarily. It can also be seen in renal conditions where the baby is putting out a lot of urine. In polyuric conditions of the baby, you can have polyhydramnios. So that's one point you have brought out, which is very good. Other thing I wanted to ask about, any medication history for the mother?
She was just on the normal multivitamins and iron and calcium tablets. She was not on any other medications.
Why am I asking for that?
Ma'am, if she was taking some ACE inhibitors, which can cause oligohydramnios.
What else? What else? Common ACE inhibitors.
Yes, ma'am.
Sometimes as painkillers, endomethacin and things also given.
Yes, ma'am.
Yes, NSAID. So these also can cause renal issues. So yes, so you've asked for those. So you have said that she took calcium, folic acid, and iron, whatever. But you should also mention no other medication like this taken. So you have showed that you know about it.
Yes,
so you just put it out there. Okay.
Okay.
Other than that, now for family history, go to the family history.
Yes, ma'am.
So whenever you have an early infant, 2-month, 3-month-old child of any system, I'm not talking about renal, any system, you can never say just non-contributory and leave it. Okay, because see, if it's different if it's an older child. This is a young baby. So most common things affecting a 2-month-old, 3-month-old, many times are congenital issues, be it heart, liver, lung, brain. Correct? So you can't leave it by saying non-contributory. You have to say what have you looked for. So you can't just say non-contributory and leave it. Because it's a small 2-month baby, right? So
Yes,
what
ma'am.
were you looking for? What have you asked? What would you want to
Any
ask? Now you've given me a
family history of
summary.
family history of chromosomal anomalies.
No, don't go. You have given me a summary, right? You have somebody with edema, oligoid, and you think it is probably renal origin. Okay, now you have to make a case stronger, right? So what will you ask in family history?
If there is
Directly
any
you
family history of chromosomal anomalies,
now you say the parents are illiterate, socioeconomic class is very
also
poor. Non-consanguineous marriage. Yes, very good. Consanguinity. What else will you ask?
What is the community of this patient? Which community it belongs? Have you taken history?
I'm not sure. I haven't asked about the community.
No, generally, if you are dealing with now, right from the beginning, you are saying that is congenital nephrotic syndrome is one of the your DD, and it has a genetic basis. So, and patient is not married consanguineously. So, if it is a community, there are some communities which have inbreeding. Inbreeding means they are basically small communities, and they keep on paper they are not related to each other, but they keep on marrying in the same small group. So even on paper they may not be consanguineous, but they behave like a consanguineous marriage. Understood?
Okay.
Like any this nomadic tribes or they have a very small number. So on paper they may not be related, but they have the common genes, common recessive genes. And that's why they, in spite of not having consanguinity, they will have autosomal recessive disorders.
I think this is a very important point. Whenever you have a very young baby and you are suspecting that this is some genetic issue, I think you should always ask about, which community they are from. Having said that, Dr. Pratichi, are you aware of any specific communities where these congenital kidney problems are common in India? Because I think largely the data is Western.
Yes, largely the data is Western. In congenital nephrotic, there is no such Indian data which has looked at communities as such. But of course, the incidence is higher in consanguinity. But it's not like, as widely seen as probably thalassemia, where you have, these communities will have thalassemia. So because congenital nephrotic as such is uncommon, correct? And there's no data to say which community. Of course, in abroad you have these Finnish populations and all that, which we say has congenital nephrotic. But India we have not yet kind of delineated one community. But yes, history of consanguinity is there. Yes.
I think there are a lot of registries for rare diseases nowadays. So
Yes.
do we have any such registry for congenital nephrotic syndrome?
We have a registry, so we are compiling the data for all these genetic conditions, at least in Maharashtra. Like all our nephrologists have submitted our data, what we have collected, and we're trying to compile the data we have. So it's not a nationalized data, but at least in Maharashtra we are doing that. So whenever we send off a genetic test, we send it off to a common. We have a email address where we send it to, and we're trying to collate that data. So hopefully Maharashtra data, Maharashtra parts of Gujarat data may come, but we don't have like a national thing, which we are for genetic conditions.
Right. Okay.
So I was still on the family history. I'm Dr. Sabad. So as sir said, you're asking about the community, you're asking about consanguinity. What else will you ask for? Very commonly, what else will you ask for? Chromosomal, it's going to be less likely in an illiterate, lower socioeconomic child. The cost itself of a testing is like 20,000-25,000. They are not going to be affording. So other marker for that, you can always ask for any other fetal deaths, any neonatal deaths. You can ask for history of, previous children who have passed away. Just to see whether there has been, because you see very commonly when in congenital nephrotic also, they have history of fetal losses in the past. Or or in any other, even in heart conditions, you may have a history of siblings passed away in infancy. So it's a very relevant history to ask about neonatal or fetal losses. Okay.
Yes, ma'am.
Yeah.
Yes,
all right. Also, specifically in renal patients, you also ask for anybody in the family having any kidney conditions. But if you ask anybody, घर पे किसी को kidney का बीमारी है, they will be किसी को नहीं, दूर तक नहीं. But then you ask किसी को कम उम्र में blood pressure का तकलीफ है, हाँ है. किसी को घड़ी यूरिन इन्फेक्शन होता है, हाँ है. किसी को recurrent stones होते हैं, हाँ है. So when you in our society, when you ask for किसी को heart का बीमारी है क्या, और किसी को kidney का बीमारी है क्या, they'll be like, no, किसी को, you know. So you ask for anybody having recurrent infections, urine infections, anybody having recurrent kidney stones, anybody having blood pressure issues in the younger age, like, you know, adolescent or young hypertension can be kidney related. So these are very valid questions you need to ask. Okay, are you clear, Dr. Sabha?
Yes, ma'am.
Okay, do you agree to what I'm saying, or am I speaking too tangent? Yeah. Okay.
No, ma'am. Yes, ma'am. Yeah. Right.
The last point you also asked is history of hearing loss. Okay, in kidney conditions, it's very, because what happens in many early kidney failures we have seen can have Alport syndrome, and which the first presenting symptom sometimes is hearing loss before the kidney condition comes in. So anybody in the, and it's all is inherited. So you always ask for history of hearing loss in the family. That's a very valid history to ask for. Okay.
Okay.
I think you can go ahead. Immunization history, the baby is small, so you have asked these two things, which is fine. But you should know, if you have a 5-year-old child with a swelling and oliguria, a similar complaints in a 5-year-old child, you need to know what immunization needs to be asked for that child. Okay, it is not for this patient, but you can probably read up about this. And we have 5-year-old with similar complaints. What vaccinations will you ask for, and what additional vaccinations you will advise? Okay, you can read up about that.
Pneumococcal influenza vaccine.
Yeah, correct. You're right. So, but not valid here. So I'm not going into. Okay, go ahead.
General examination. Child was conscious and active. Pulse rate was 130 per minute, measured in the right radial artery with regular rhythm, normal volume without radial and radiofemoral delay. All peripheral pulses were well felt. Respiratory rate was 46 per minute, abdominothoracic type of respiration without any signs of respiratory distress. SpO2 was 98% in all 4 limbs. Blood pressure was 80/50 mm of Hg, measured in the right arm supine position. Edema present over the face and abdomen, and pitting type of edema present over the upper and lower limbs. Pallor present over the oral mucosa, conjunctiva, and over the palms and soles. Anthropometry, weight was 3.7 kg, which was...
Dr. Sabat, I'm sorry. Just go back a minute. Yeah. So you said blood pressure 80/50, no? So what cuff have you used, and what device have you used?
Ma'am, it was a NIBP cuff, ma'am.
NIBP cuff. Okay. So how do you know that cuff was not too big for the child?
It was inappropriate. It was the cuff was about 2/3 of the upper.
In short, madam, asking what is appropriate cuff.
Yeah, the cuff length was 2/3 of the arm length, and it was encircling the arm circumference.
The bladder was encircling, or what was encircling?
The bladder.
So the bladder should encircle at least 80% of the circumference of the arm, and latest guidelines say the width of the cuff, you know, the width, if you hold a cuff straight like that, the width of the cuff should be at least more than half the circumference of the arm, the width of the cuff. Okay, so now this is 2/3 things. Now we are going towards these newer guidelines, which say first thing is the width of the cuff should cover more than 50% of the circumference of the arm, like this. Okay, the width, and the length should cover at least 80% of the circumference.
Okay, ma'am.
That is the latest guideline. It is different from what it used to be in the past, but it's the latest guidelines which say how you measure for blood pressure. And NIBP is not the best method for measuring, though it is the most convenient one, practical one for us. Always remember, if in an NIBP, anytime you have high blood pressure, always confirm with a manual blood pressure. Okay. Okay, so NIBP is good for screening, but it tends to give slightly higher read. So if in an NIBP, which is basically an oscillometric device, if it gives you hypertension, always check with a manual blood pressure. Okay, always remember this rule. Secondly, edema. How have you checked for edema?
Check for edema, like it was a pitting type of edema
How
in
check?
the upper
How
and lower
have you
limbs.
checked? How?
In exam, you're asked to show the.
Over the
So,
shin of the
You can show on your hand or something.
over the shin of the
How
lower
much?
limbs.
Yeah.
I
yeah, yeah.
Where will
Continue.
you
30
apply? How
seconds.
much pressure will you apply? How many minutes will you apply?
30
Or how many
seconds
seconds will you apply?
is applied,
Come
and
again?
then you have to see for pitting or non-pitting type of edema in those patients.
No. Site, duration of
Site is over the
pressure, and
shin
how
of
much
the
pressure?
shin of the lower limb, leg,
Okay.
and shin and the medial malleolus.
How much duration will you apply the pressure?
30 seconds duration, the pressure is applied, and then when the finger is removed, you see for the pitting type of edema.
Go ahead. Go ahead.
Sabat, I want to ask you something. What are the factors that decide blood pressure? What are the important factors you should know that affect blood pressure of a child? So what are the parameters that are important when you check blood
The
pressure?
child should be
How do you decide this is normal, abnormal?
The child should be calm during the blood pressure evaluation. Child shouldn't be crying. The child shouldn't be in pain. Child shouldn't be hypothermic or hyperthermic.
Right. And what does it depend upon? Suppose I just tell you 4-year-old child blood pressure is 90/60. Does it help you?
Depends on the height and sex and the age of the
Very
child.
good.
These are the
Yeah. So
parameters.
3 factors are important. Okay. Yeah. Go ahead.
Proceed.
Yes.
The weight of the child was 3.7 kg, which was with edema. Length was 50. The weight was less than -3 standard deviation according to the WHO growth chart. The length was 52 centimeters against the expected of 58 centimeters, which was again less than -3 standard deviation. Head circumference was 38 centimeters, which was at the 50th percentile according to the WHO growth chart. Head to toe examination. The head was normal shape and size. Anterior fontanelle was open and measures 1.5 into 1.5 centimeters. Posterior fontanelle was closed. Eyes, ears, oral cavity examination was normal. Puffiness over the face around the eyes noted. No facial dysmorphism was noted. Neck, no swelling observed over the neck. No dilatation or engorged veins seen. Chest or thorax, normal shape and symmetry. No evidence of any chest deformity observed. Extremities, general examination of the upper and lower limb does not reveal any gross abnormality. Edema was present over all 4 limbs, which was pitting type. No cyanosis was observed. BCG scar was seen. Spine was normal shape. No evidence of any swellings present. No neurocutaneous markers were present. Systemic examination. The child was examined in supine position over the bed. Per abdomen findings. Inspection, abdomen is distended, skin over the abdomen was shiny, flank fullness was observed, umbilicus was in normal position and stretched. Abdomen moves equally on respiration in all quadrants. There were no scars or sinuses seen, no engorged veins seen. All hernial sites were intact and the skin over the scrotum was shiny. Palpation,
No ascites.
superficial palpation.
There was no ascites. Distension was not there. Ascites was not there.
I was like in palpation, so percussion.
No, but distension, abdominal distension was not there.
Abdominal distension was there, sir.
Okay.
Palpation, superficial palpation. There was no local rise in temperature, no tenderness, and no rigidity. On deep palpation, bilateral swellings palpated in the lumbar regions with a rounded edge, non-tender, bosselated surface, and firm in consistency, and measuring 9 centimeters in length on the left side and 8.5 centimeters on the right side. Swelling is palatable, moves slightly with the respiration, and fingers can be insinuated between the swelling and the rib cage. Abdominal girth was 36.5 centimeters. On percussion, there was no shifting dullness or fluid thrill present. Auscultation, the bowel sounds were heard normally. Other system examinations were normal, sir.
Okay.
Final diagnosis. 2-month-old male child with subacute
So,
onset.
Sabat, what has your examination added?
It has shown that there's edema present, pallor was present, and there were bilateral swellings were palpated in the lumbar region.
It checked for
And
free fluid in the abdomen. Have you checked for?
yes, so shifting dullness and fluid thrill was it was absent, sir.
Okay. So there was no free fluid according to you in the
Yes,
abdomen,
sir.
or not to the extent
That
as
it
to
would
cause
present
these
shifting dullness.
signs. Okay, but I don't agree with your diagnosis. You directly jump to the congenital nephrotic syndrome. It may be, but this is not the way to deliver the diagnosis in an exam. You should say Anasarca and stop there. And then the examiner will ask you, what is your differential diagnosis?
Okay.
Apparently, it's like my diagnosis is Anasarca. I would like to give differential. You have to say, I would like to give differentials.
Yes, sir.
Why not? It is some protein losing enteropathy causing generalized Anasarca. I have seen patients of same age, 2 months, 3 months, with generalized edema, failure to thrive due to the protein losing enteropathy. They are also very rare, as rare as.
That is why I asked Dr. Sabat, what is in the examination that will help you to say that this is renal origin?
The ballotability of the mass and the site of the
So
mass was in the.
you should be able to say that, isn't it? So you say that it is not likely to be protein-losing enteropathy because we have a renal mass, bilateral mass palpable, which is likely to be kidneys, right?
Yes, yes.
How else will you say that this is not a loss of protein from some other site?
In nephrotic syndrome, every time in nephrotic syndrome you have bilateral masses.
No, not always, sir. In congenital nephrotic syndrome, there can be enlarged kidneys present or ballotable kidneys present.
Yeah, in fact, it is not common. No, if you
in-
see a typical child with nephrotic,
No,
are
sir.
you likely to find palpable kidneys
No, sir.
or palatable kidneys? No, isn't it?
No. Yes, sir. For protein losing enteropathy, there was no history of any dehydration or any excessive vomiting, prolonged or chronic persistent vomiting. History wasn't there.
They will have diarrhea or vomiting. What will they have?
No, diarrhea. There was no history of diarrhea or.
Okay.
So no GI symptoms. Basically, you
No
will
GI
say there was no gastrointestinal symptoms. And what else will you get? Suppose you get protein losing enteropathy. What else is not absorbed?
Fats are not absorbed and
Yes.
other multivitamins. I'm sorry, I mean
Most
micronutrients.
micronutrients will be deficient. The child is likely to have deficiency. Here you have anemia. Can you explain why this child is anemic?
So the child
You
is
said there is
too
significant.
Normally in nephrotic syndrome, what should be the hemoglobin?
The nephrotic syndrome due to hemoconcentration HB. I mean, there wouldn't be any pallor, or there would be a waxy pallor seen because of the edema.
Very good. Yeah. So they may appear to be pale, isn't it? Because of the edema, the skin may appear to be pale. But how will you confirm whether it is real anemia or not?
We have to see the mucosa.
Good. Yeah. So the skin may appear, waxy and pale. The mucosa will not get so much affected, isn't it? So you can look at the tongue, you can look at the other mucosa and say if anemia is there or not.
Why not? It is a congenital infection.
So the child had no history of fever, lethargy, irritability, anything which would point to a infective child. Child was not a sick-looking child on the history or examination. Child was conscious and active.
But you said this child is malnourished, isn't it? So with edema, his weight is less than the third centile, I think, right?
Yes, sir.
So there is definite failure to thrive. So what sir is saying is that this is a torch group of infection, or this is some infection, congenital infection, which is also involving the kidney.
The birth history is not significant, sir. But child was a full-term baby with
But
no
your
history of
history is not fitting properly. You are saying it is 8 days history, and there is a failure to thrive, and there is a edema. So which is first? The failure to thrive is first, or edema is first, because failure to thrive cannot set in 7 days, 8 days. We cannot have a weight loss.
Probably the mother mustn't have noticed it before, but she started noticing only 7 days back, and this diseases must have started since birth only. And child was, that's why, not thriving well since birth, and that's why child's weight is less than -3
So your
centimeters.
history is not fitting. Maybe mother is responsible for that, but it is not fitting into. Failure to thrive indicates that it is at least a month old, story from the time of presentation.
Yes.
Okay.
Okay. Yes, sir.
What about congenital syphilis?
Can it cause nephrotic syndrome?
Is not seen nowadays?
Sorry, sir?
Is it seen or not seen, congenital syphilis? Is that
It's seen
disappeared?
very rarely. The incidence has come down since before.
Incidence had been almost zeroed. Now it is again coming back. So congenital syphilis is bouncing back, not in a very high, a big way, but it is in between years. It was not there, but it is coming back because of the loss of number of HIV cases decreased. The precautions that are taken for the HIV are no longer taken, and that's why all the venereal diseases are on the rise again. And that's why congenital syphilis, few cases we have seen in last 1 to 2 years. Very number is less, but congenital syphilis is one of the cause of nephrotic syndrome under 1 year of age.
Sabat, I would like to ask you, if you have bilateral palatable masses in the abdomen, what would your DDs be?
Just with
of those palatable masses.
Any congenital anomalies of the kidney and ureter bladder.
Any means what?
I mean,
Suppose there is unilateral absent kidney. Will it be bilaterally palatable then? No. So any specific you want to tell us?
Dysplastic kidneys, autosomal recessive PCKD, and congenital nephroblastomas.
Okay.
And horseshoe-shaped kidneys and hydronephrosis due to obstructive uropathies.
Yes.
Is it a male child or a female child? Is it a male child or a male child?
Dr. Pratichi, would you like to tell us more about, how often do you find this kind of palatable kidneys at this age?
So exactly, I was going to talk about that. It is frankly very rare to find the kidneys to be so easily palpable. Like, he's also, you have said, bossulated surface and all that. It's very rare unless you have some cystic diseases of the kidney. Only when you have some cystic disease of the kidney or there is obstruction causing severe hydronephrosis is when we easily feel the kidneys. In nephrotic syndromes, even congenital nephrotic syndrome, it is not common to have very enlarged, you'll have enlarged kidneys in an ultrasound, but clinically, you usually don't pick up very big bulky kidneys. Though they'll be bulky on ultrasound, but clinically, only cystic disease of the kidney and hydronephrosis due to obstructions can give rise to such bulky, palpable kidneys, and tumors, of course, can give rise to such palpable kidneys. Usually, nephrotics don't come with such palpable kidneys. So I'm very surprised that this child has such severe edema. 2 months old.
If Sabha should be made, she's given passing marks, or should be passed only on palpation, because palpating a neonatal kidney if he has done his own, he should be congratulated for that.
So it
Yes,
is very
definitely.
difficult. It is very difficult. Frankly, it is very difficult. Only if it's very enlarged, you feel it. And another thing, if your child has such severe edema that you're having pitting over the limbs and he has zero ascites, again, is very uncommon. You know, where does Dr. Sabat, why do you have ascites? Okay, it's
the ascites must have been present, but the trying to demonstrate a shifting dullness on that side was a little difficult, ma'am, because child's very like 2-month-old. That's why child was a little irritable for that procedure, ma'am.
Is there a smiling umbilicus?
Yes,
there is no
the
smiling?
umbilicus was stretched.
Exactly.
Umbilicus
That's all.
was stretched.
Exactly.
Enough.
That
You
tells
can
you there
say
is free
that
fluid.
it was
There is
very
free
difficult
fluid.
for me to demonstrate
Yeah.
because of the irritability of the child or small size of the baby.
Exactly. So you should say that, Dr. Sabawa, that I could not elicit shifting dullness because the child was very irritable. You can't confidently say there's no shifting dullness. That contradicts the entire examination. So you saying that I could not elicit because the child was irritable is understandable. We all understand. We are pediatricians. So we'll understand, okay, the baby was crying too much. Because in exam situation, in otherwise clinical situations, I would never take this for an answer because the child sleeps sometime during the day and you can elicit the signs. But for exam situations, fine. The child was irritable, so you couldn't do it. But smiling umbilicus, severe edema enough to cause pitting over the limbs, you will have some ascites. So you can say that I could not elicit. That is a fair answer. You can say that.
One more thing is that the child had bilateral swellings in the flank region. The swellings of the kidneys were so obvious and it was
Really?
palpable also. So probably that could have been attributed to that shifting dullness. That was one thing that came to my mind. That could make
Sabha, a standard question asked in the exam. So just for everybody who is listening, what is the difference, pathophysiology difference in the edema of a nephrotic syndrome and a nephritic syndrome? Both are having edema. What is the difference in the pathophysiology? Can you tell us?
The nephrotic syndrome, there is abnormality with the porocyte and the slit diaphragm, where the proteinuria is massive because there is effacement of the food processes and the slit diaphragm is permeable to the albumin. So that is why there is massive proteinuria and that is why there is massive edema in them. And in nephritic syndrome, it is more of a glomerular abnormality, because of which there is mild proteinuria and hence there is no massive edema.
Oh, you have
no
not answered. You have
no
not answered sir question properly.
Pathophysiology. So that if once you understand pathophysiology, you will be able to employ the drugs. Otherwise, you will employ wrong drugs for the edema.
Why there is Sabat? Why is there edema in glomerulonephritis? Why is there edema in glomerulonephritis? No, don't tell us theories. Tell us why there is edema in glomerulonephritis and how is the edema in glomerulonephritis, and then you can contrast with nephrotic.
So you had already mentioned that there is a hypovolemia in nephrotic syndrome. So you know something, but you are not able to express it.
Hypovolemia causes
nephrotic
it
syndrome.
stimulates the RAS system, so more of fluid is absorbed again. I mean, it does not let the it does not increase the glomerular filtration rate again. With the massive proteinuria and also with the because of which there is decreased intravascular volume, it activates the RAS mechanism, and again
that is what is that is called as technical terms. Activation of
RAS, renin-angiotensin system.
It is a secondary hyperaldosteronism in response to the hypovolemia. So that is there in all edema where there is a hypoproteinemia. May it be nephrotic syndrome, may it be protein-using enteropathy, it be hepatic. Wherever there is a decreased colloid osmotic pressure, there is edema because of that. There is a hypovolemia. Extravascular fluid is more than the intravascular, and the intravascular fluid is less. That's what causes activation of renin-angiotensin system, accumulation of more sodium and water, which again goes into the extravascular space.
Yes.
So, and exactly opposite to that, what is the problem in the edema in your nephritis is because of increased hydrostatic pressure.
Yes, sir.
The colloid osmotic pressure is same, but hydrostatic pressure goes beyond the colloid osmotic pressure, and that's why there is edema. So, most important thing in here, message from here is there are people who are treating hypertension with a ACE inhibitor in case of nephritis without understanding the mechanism. So, where there is hypervolemia, will you only employ the diuretics? And in the case of nephrotic, you will employ diuretics with the what?
ACE inhibitors.
Not ACE inhibitors. You want to block the aldosterone. You want to block the aldosterone.
Spironolactone.
The spironolactone is must in the management of the edema caused by the hypovolemia.
So, but suppose you start spironolactone today, how soon does it take an effect?
Takes
Suppose you
around
start
1
it
week
today.
to 10 days, sir.
So
1 week
it's a
to
slow
10 days.
acting drug.
It's a slow acting
And
drug.
what about furosemide?
Furosemide acts soon, very fast, sir.
Yeah. So the mechanism is different, isn't it?
Yes.
Sir very rightly put it. Whenever you have a child with edema, it is very important to find out what is the cause of the edema, because the treatment is different. And if you treat it interchangeably, the outcome will not be very good. So as Sir said, whenever there is nephrotics, whenever there's edema, to figure out whether it is due to decreased oncotic pressure or is it due to increased hydrostatic pressure. The treatment will vary. So all vary. So always when you have edema, try to figure out by history and examination what it is. Usually the treatment, this child is small, but usually the edema of nephrotic syndrome is a very severely pitting edema. And in comparison, the hydrostatic pressure edema can also be pitting, but not as much as the nephrotic syndrome edema, and it's more because of the stretching or because of hydrostatic pressure, right? So the skin looks a bit more stretched, and the pitting is not as much as that in the nephrotic edema. This happens only as you see more and more patients with edema. You'll do pitting in all of them. You'll figure out the difference. But the pitting is more prominent always in the nephrotic as compared to the nephritic patients. Okay, so but that is only with practice. As you see more and more patients,
I think it may be related to the duration of the process also.
Yes, sir. Of course.
Nephrotic edema develops per day.
Of course.
And that's why the skin stretching is allowed. And in any nephritic syndrome, the skin develops within maybe days rather than weeks in nephrotic.
I think I want to. So I would like to add, Dr. Ambedkar always says that in nephritis, the patient will get edema in his lungs first.
Yes.
Yeah, and then it will come onto your, noticeable edema. So the patient will come to medical attention much earlier, isn't it?
Yes.
A nephrotic is a happy child. He is a happy child with edema. Nephritic is not. So that is, I think, what we should remember.
Also, Dr. Sabbath, what are you looking for in the respiratory system in this child?
Signs of volume overload with pulmonary edema, crepitations will be present on examination. And
will you have, go on.
Inspection, there will be respiratory distress with tachypnea.
No. So you have a congenital nephrotic child, you're saying, no? You have a nephrotic syndrome. What will you see in that? What will you see? Pulmonary edema, or will you see something else?
Pulmonary effusion.
Pleural effusion.
Sorry.
Yeah, because again, the cause of the fluid coming into the pleural cavity is different. Here, because of decreased oncotic pressure, you'll have pleural effusions in nephrotic syndrome. While in glomerulonephritis, you will have edema, the pulmonary edema. There's fluid in the alveoli. Okay, so you'll have creps in edema, and you'll have, decreased air entry, dull on percussion in effusions. Okay.
I think let's go for the management.
Yes, sir. The management usually with congenital nephrotic syndrome.
What investigations do you have, Dr. Sabat? Management includes diagnosis also,
diagnosis.
Right? Diagnostic tests. Yeah.
Okay. Diagnosis, I would like to see for complete hemogram first, because since there is parallel examination, so that is why I would want to see for hemoglobin, and then a urine analysis, where I would like to see for urine albumin and spot urine protein create ratio, or you can also do a 24-hour urinary protein levels, and then lipid profiles can be checked to see for hypercholesterolemia, which is
24 hours urine nowadays is not recommended. Huh?
Yes, sir.
Instead of it has been taken out of the all recommendations, and instead of that, spot protein creatine ratio has come.
Yes, sir. Yes, sir. Lipid profile would be checked, and I would do a USG abdomen and pelvis, ultrasonography of the abdomen and pelvis. Since the renal masses are palpable, I would like to see for any CM differentiation. And also,
what about cyst? Will you expect that there will be cysts on the ultrasound? Madam said no.
Yes.
If you have large palpable kidneys, then usually cysts, right?
Yes, sir.
Can you tell us the investigations in this child, what you've done?
Investigations which were done antenatally at 12 weeks, ANC USG abdomen revealed a nuchal translucency of 3.1 mm, which was told to be abnormal by the radiologist. Following which a quadruple test in the second trimester at 18 weeks was done, which showed the risk of trisomy 1821 and neural tube defects was low. On admission, urine analysis was done. Urine protein creatinine ratio was 44, which was very high. Urine albumin was 2+. Urine RBC and RBC cast were nil. Triglycerides, triglycerides were very high, and hypercholesterolemia was there. Also, LDL was raised. Serum BUN and creatinine was normal. USG abdomen and pelvis was done, which was suggestive of bilaterally enlarged kidneys with preserved corticomedullary differentiation of size 7.7 into 4 centimeter in the right kidney and 7.8 centimeter by 3.9 centimeter of the left kidney. TSH was done, which was high, raised of 26, and serum sodium was 130.
Complete T4 was normal or less than normal?
Sorry, sir.
T4, T3.
No, T4, T3 were total T3, total T4 were normal range, sir. But T3 was raised.
Serum albumin?
Serum albumin was 1.6, sir. So I haven't mentioned that.
That's important. I think you should have mentioned it.
Total proteins? Total proteins how much?
3.5, sir.
Total protein 3.5.
Yes, sir.
Okay.
So Dr. Sabat, you've done some investigations. So nephrotic syndrome is the triad of edema, proteinuria, and hypoalbuminemia, right? So, so edema you've shown us that you have. Hypoalbuminemia, you said you have albumin of 1.6. Now nephrotic range proteinuria. Let's talk about that. So what is pointing towards that here?
Urine protein create ratio, spot urine protein create ratio was very high with 44.
What is the normal protein creatinine ratio?
In less than 2-month-old children, 0.5 is considered as, sorry, less than 2-year-old. is considered as 0.5, less than 0.5 as to be normal, and more than 2-year-old it is considered to be normal with less than 0.2.
Okay. And what is nephrotic range proteinuria?
Nephrotic range proteinuria is more than 2. Urine protein creat ratio, if it is more than 2, or total proteins urine in the urine is more than 40 mg per meter square per hour.
Very good. It's more than 40 mg per meter square per hour. That's what we do in pediatrics. In adult, they use the number of 3.5 grams per day. But in children, you have to quantify according to the body surface area. So more than 40 mg per meter square per hour. Okay, very good. So we ideally, though, in older children, 24-hour urine is expected, but in smaller babies, how are you going to collect it? Is it practical to always catheterize every child and collect 24-hour urine? It is not. So in smaller children, we accept the spot protein creatinine ratio, but in older children who are able to give samples, in older children, we still prefer the 24-hour urine protein ratio, not the ratio, the 24-hour protein. But in smaller children, it is not practical to ask the families to kind of collect that. So we say spot is accepted, and all our guidelines are nowadays using spot.
Had changed the guidelines again.
No,
IAP guidelines have removed 24 hours. Had removed. I don't know. Again, off let they have changed again back to.
No, sorry, in smaller children, it is not practical. So we always
for everybody, the 24 hours is not recommended in IAP guidelines. Not practical.
In older children, sir, we still
don't know.
Yeah. So three things. Other thing is that triglycerides are very high and cholesterol is very high. Other thing, let's talk about the TSH now. Why is the TSH high, Dr. Samal? Why is the TSH not so high?
Usually there is loss of thyroglobulin and thyroxine hormones through the urine in nephrotic syndrome.
So?
Sorry, thyroid binding globulin. So that is why there is, due to loss of thyroxines, the reflex hypothyroidism occurs and TSH is raised in them.
Correct. So do all that. So what about the other nephrotics? This is a congenital nephrotic. What about a childhood nephrotic? If a child has come to you in relapse, an active relapse, so is secreting a lot of protein, and you do the TSH at that time, what will it be? Just think about it. Even if you don't know, let's talk this together. Okay, so it's a 5-year-old child has come to you in a relapse. So his protein is urine protein is 3+, 4+, and usually don't do a TSH, but somebody has advised a TSH. Okay, so what will the TSH be?
Raised.
It's raised, but what happens in childhood nephrotic syndrome, once the proteinuria gets controlled, this TSH also normalizes. So usually these children don't need treatment with thyroxine because we are able to control the proteinuria and able to control the loss. So they don't require treatment with thyroxine. However, in congenital nephrotic syndrome, there is no medication as such. There is no one magical drug I can give the child to stop the proteinuria. So these children many times do require supplementation with thyroxine because they have come to very early in life, right? 2 months of age, 1 month of age, 3 months of age. So, and this protein loss will continue for a longer period of time. It's very difficult to control the proteinuria of congenital nephrotic. So these children do require supplementation with thyroxine. Okay, remember that. So if you see an older child, don't just start off with the thyroxine because usually it gets controlled. Usually the TSH comes back to normal once the proteinuria subsides. But in congenital nephrotic, it is very difficult to control that proteinuria. And the growth will be affected, the development will be affected. So these children are supplemented with thyroxine and we do monitor the thyroxine levels. The other thing was about anemia. So can there be anemia in nephrotic syndrome by itself in congenital nephrotic? Just like you're losing protein, what else are you losing in the urine?
Transferrin.
Transferrin, correct. You're very correct. So you lose transferrin in the urine, which can lead to anemia. Okay. Along with that, you should be also aware what else they are losing in the protein in the urine for infections. Why are we giving them pneumococcal vaccines? What are they doing?
Immunoglobulins are also.
Why this difference between the that later onset and congenital?
Sir, because
I'm asking him.
Oh, you're asking him. Sorry, sir.
Why there is a difference? Let me see whether I understood.
Sorry, sir.
Why there is difference? Why in congenital nephrotic syndrome you need to, everything is going down the drain, and in later on it is not going.
Because the infants have the tubular reabsorption capacity is also very less in them. And older
that is not the reason. That is not the reason. What is selective proteinuria and non-selective proteinuria?
Selective proteinuria.
In which conditions do you have? In which
Yes,
condition you have a selective proteinuria or albuminuria? For that means albuminuria. Why albumin comes first? What is the molecular weight of albumin?
66 kilodaltons.
68,000 kilodaltons. So albumin is the first molecule. So injury is minimal, the albumin will start passing. The injury is more and more larger molecules will pass. And that's why in your minimal change nephrotic syndrome, we don't see all the other things, because injury is not that severe as compared to congenital or maybe MPGN and other chronic diseases. And that's why here, if you check the albumin globulin ratio, it may be normal in your patient because both are gone down. So the AG ratio may have preserved at a lower level. The ratio may be low, same with the low levels, because globulin is also going down.
Yes,
that's why they congenital nephrotic syndrome have a lot of infections. They require immunoglobulins, so on and so forth.
Okay.
My last question on this slide is, why is your sodium 130? So very commonly, you'll see nephrotics who come to you with low sodiums. First question is, why is it low? And then automatically you know the answer of, do you need to treat it?
Dilutional hyponatremia is there, ma'am, because of the retention of the fluid.
But the fluid is not in the vessels, no? You said the fluid is where extravascularly, right?
Ma'am, there are two theories, and this overfill theory. There is
don't go there. Don't go there. Don't go there. Don't try to complicate it. It's very simple. I'll tell you the answer.
What is spurious hyponatremia?
Because of the increased lipidemia, because of the hypertriglyceridemia.
In which other condition you see it? Which is present in the PICU. It comes in the PICU.
Glucose.
Yeah, okay.
There also, which is much commoner than the congenital nephrotic syndrome. DKA.
Yes, sir.
Yeah. So here the sodium is 130 or it's low, because what happens is all your fluid has gone extravascularly into under the skin, right? And intravascularly the effective circulating volume is low. Correct. So the body senses it as if it's dehydration, right? We already spoke about it. So what happens because of that? The ADH, the antidiuretic hormone, is activated and it goes up, which causes retention of free fluid and can give rise to hyponatremia. So very commonly you'll have nephrotic patients with 125, 126 sodiums, but we should not be tempted to treat them with sodium, because if you give them sodium, you will worsen the edema. Correct? It's a case of sodium retention as well, right? So you never give them sodium. Once the edema decreases, once you treat this child with albumin and furosemide, this sodium will normalize by itself. We don't need to give sodium. Giving sodium will only worsen things.
Same thing applies to the chronic liver disease.
Correct.
Yes. They don't treat hyponatremia unless they are symptomatic.
Correct.
Unless symptomatic, hyponatremia in a chronic liver disease are not to be treated.
Yeah.
You can go ahead.
Should I proceed with management?
Yes, please go ahead.
Treatment usually in congenital nephrotic syndrome, they are non-responsive to the steroids or any other medication. So we give supportive theory treatment for clinical sequelae of the nephrotic syndrome, like the edema, which is treated with either albumin or if there is effusion, if there is signs of volume overload, then we would give furosemide. Albumin is given in this case because one point the serum albumin was very low, and then other clinical sequelae like they are very prone for infections, so we would, in an older child, we would vaccinate them. And then if there are thromboembolism episodes, then we would start them on anti-platelets or anti-coagulation therapies. Since the TSH was very high and this child is very young with a developing brain, we would also start with levothyroxine in such patients.
What have you done for this child? Have you put it down? And what have you done for this child? Have you written that as well in the slides?
No, ma'am, I haven't mentioned in the slide.
Okay. Can you tell me in short what has been done with this child?
Ma'am, albumin was given, and since the child was very anemic also, child was transfused with PCV, and also NVAS was started, ACE inhibitors was started, and Hyroxine was started, ma'am.
So why was NVAS started? Why was an ACE inhibitor started? You're correct. It was started, but do you know why it was started? What is the role?
It helps in, decreasing the proteinuria. So
how?
Because it's it acts by mechanism of preventing the RAS activation. So
whenever we are talking about management of a congenital nephrotic, there are only basically just three main factors you have to look at. Okay, one is fluid management, one is antiproteinuric agents, and third is supportive. Okay, in fluid management, you will have to restrict the fluids to how much child requires for his insensible losses plus urine output. Okay, so when the child is with you in the ICU or in the ward, you have to monitor his daily urine output, and his daily requirement of fluids must be his insensible losses plus his outputs. Okay, so what are insensible losses for this boy? How do you calculate it?
400 ml per meter square.
Perfect. So your fluid intake must be insensible, that is 400 ml per meter square plus all his losses. So you have restricted his fluids. You can't let him keep drinking how much ever he wants to drink, because that will cause more edema. That is one thing. Secondly, how will you tackle the edema? What are you going to do with the edema? You said it. You said it. Say it again.
Albumin infusions.
Along with?
Diuretics.
Correct. So you will give albumin plus diuretics. Okay. How much albumin to give, when to give albumin is not dependent upon the serum albumin level. Today the serum albumin is 1.5, so I'm giving albumin. It is not like that. It's always clinical. If clinically the child is stable, not too puffy, not looking too sick, no edema causing breathing discomfort, you can even hold albumin for the day if the albumin is 1.5. This child is going to require a lot of albumin, even going forward. So you have to be very sensible in deciding when to give. That his albumin levels are never going to become 2.5, 3, 3.5, never, because he's always going to lose protein. So our judgment when to give albumin is purely clinical. Clinically, if the edema is stable, you will not give albumin, even if the albumin levels are low. If
voice is breaking, your voice.
You can't hear me? You can't hear me properly?
Voice is breaking.
Now you're audible. You're audible.
Okay. So I was saying the albumin infusions doesn't depend upon the level of the serum albumin. It depends upon the clinical status of the child. Because this child is never going to have a normal looking albumin. He's never going to have an albumin of 3 and 3.5. So the decision to give albumin infusions depends upon the clinical examination. Okay. So sometimes you may start off with daily infusions. Then you say, okay, I can back off, give once or every 2-3 days, then maybe once a week. So it's all clinical decisions. This is not depending upon the levels. That is a fluid part of it. second part of it is the anti-proteinuric agents. So medicines we need to give to decrease the proteinuria. As you rightly said, we can't give steroids because steroids will not respond. Okay, the child will not respond to steroids. So what you give is some agents to try to decrease the proteinuria. So you will give ACE inhibitors like enalapril, and in very severe proteinuria, we also give endomethacin. Both of them decrease the proteinuria. But what is the main side effect of both these drugs? Dr. Samavat, do you know that? What am I worried about when I'm giving these drugs? Enalapril or endomethacin? What am I worried about?
Hyperkalemia.
What else? Yes, you're right. Very good. Hyperkalemia. What else?
The bradykinin, that system is activated. So
Okay, let's talk again. Always talk like in a simple term, you know. So see, so basically both these medications act by decreasing the GFR and hence decreasing proteinuria. But if you run behind decreasing proteinuria, your GFR may decrease so much that you may induce kidney injury. Correct?
Yes,
so it's a fine balance of preventing proteinuria versus worsening of AKI. So we have to figure out the right balance, and for every child, this balance is different. Okay, so fluids you have done, proteinuria you have control with NVAS. Next, if required, you may start endomethacin. If with NVAS there's no help. Lastly, it is supportive, as you correctly said. You mentioned everything. You mentioned about anemia. You mentioned about the thyroxine. The child will require protection. Sometimes we also give IVIG to protect infections, though it's not recommended anymore, but it is still given in practice sometimes. Yeah, so these are, and nutrition. The most important thing in these children above everything else is nutrition. This child is losing grams and grams of protein every day. Okay, you have a child who with edema also is less than 3rd percentile. So how are you going to ensure good nutrition? Many of these children will require NG feeds or gastrostomy feeds to keep up with that protein loss. Okay, so what are you doing for feed nutrition for this child right now?
So, ma'am, actually, the child took medical advice.
Okay.
We had actually started with high calorie, high protein diet.
Yes.
Our plan was to reach the protein requirement of 3 to 4 gram per kg per day, and calories of 130 calories per kg per day. But the child
is it a first baby? Primary?
First baby.
Right.
First baby.
Have you done DNA? Advised them about
We had advised them, sir, but they were not affording. So the child actually required dialysis. So say.
Dialysis? Why?
No, the child had taken discharge against medical advice. So.
Okay. Did you say the child required dialysis? No, I misheard that, right? Or...
No. A child took discharge.
But nutrition is the most, it's the most ignored thing which happens in most babies with chronic conditions, right? Because we are, we are after these albumins and we are after these enalapril and after these medications, we forget something as basic as nutrition. If we don't give the child good nutrition, the child is not going to grow, whatever you do. Okay, so instead of a high protein diet, what we advise is an adequate protein diet. Okay, so don't use the word high protein diet because that is not advice. We say adequate protein diet.
And difficult to give at 2 months also. 2 months.
Yes, yes. Very difficult.
So what is the role of people who have tried nephrectomy? What is the role?
Yes. So
reduces the protein.
Get rid of the protein loss.
Proteinuria.
Yes.
Na raha baas na baje basuri hai.
No, so actually, this nephrectomy and congenital nephrotic was my research topic during my training. So I had studied all the children with congenital nephrotic who underwent nephrectomy, unilateral nephrectomy. So what they do in in Western countries is they remove both the kidneys.
Yes.
Okay.
Yes.
They remove both the kidneys and they put the child on peritoneal dialysis. We neither have those kind of resources to provide the child PD for so long because everything is chargeable to the patient. In Western countries, it is government funded. So, dono kidney nikal bhi diya, so the PD is supported by the government. Then they came up with a thought, okay, we won't take off 2 kidneys. Let's take off 1 kidney and see. then if we take off one kidney, then maybe the proteinuria may decrease by half. That was a thought.
That is not possible.
But that didn't happen. That didn't happen. The other kidney failed even faster. So now it's going towards somehow preserve these kidneys till we are able to transplant the child. But if the nephrotic syndrome causes a lot of problems like recurrent infections, recurrent thromboembolisms, then we must take out the kidney and start dialysis. But it's easier said than done because it is difficult. But that is what is recommended.
From an Indian point of view, having a genetic diagnosis and preventing the birth of a next child is far more important. Resources should be directed towards that. The resources should be directed there.
Correct. So now, yeah, that's very true. That's very true. Many times when there are history of fetal losses, for the next pregnancy, what we have seen is that the fetal medicine specialist will do chromosomal analysis. But this chromosomal analysis doesn't look for the mutations of nephrotic syndrome, right?
No, even if this patient is not affording, what you can do is take out the DNA, which costs 1,000 rupees, and it can be preserved for years together. So take out the DNA, keep it in the DNA bank, and after 1 year or 2 years, 1 year or 1.5 years, when he gets funding, do the exome. Okay.
Yeah.
That is any difficult case, any doubtful case, take out any dying undiagnosed patient, take out the DNA. And it costs 1,000 rupees only for separating DNA and keeping it under for 1 year.
I think Dr. Sandhya wants to add something.
Yeah, hello. Yes, actually, we have looked out at this patient. This patient clinically looked like Anasarca, but his weight was not. I mean, if you look at the birth weight, it was 3, and at 2 months, it was 3.5. So biochemically, he looked like nephrotic syndrome. He had heavy proteinuria. He did have, but USG radiologically, he had infantile polycystic bilateral kidneys, and his urea was also on the higher side. So we were little as far as this case is concerned, we were just in a
So
thing
he had
that
polycystic kidneys.
yes, his USG has showed bilateral infantile polycystic kidney, and his urea is also very high. So this baby has foxed us from the beginning because that Anasarca was there, but the weight was not more. We did the biochemical parameters which showed hypercholesterolemia, triglyceride, hypoalbuminemia, and the urine protein also on the higher side. We did a USG kidney, and because they were palpable, we took a second expert opinion, and we found that because they were quite obvious on inspection in the flank. So we thought whether we are dealing, at least I thought it was also, we were thinking, so we took an opinion and we found that there were infantile polycystic kidney with a high level of blood urea. So all these things came into a packet and we really did not know whether, but we have treated him as a nephrotic syndrome. We have treated him with thyroid, with nutrition. And so that was little
Biopsy not
no, actually, we had referred him to a nephrologist, but some of the other patient did not want to stay in either of the hospitals. And actually, we have his number. We'll try to follow up with him probably.
Frankly, for this child, more than a biopsy, a genetic testing will help us more.
Nowadays, genetic testing works out cheaper. And I had last week, I had a case of looking like a GSD. So instead of going biopsy, we are going reverse sequence. We have sent the exome, and if it's not going to yield anything, then we are going to go for the biopsy. If it yields something, exome, then the biopsy is saved. And
for many diseases,
yeah.
Even for Wilson, I think now the standard is the genetic test rather than doing a biopsy and copper and stuff. So a lot of diseases are now being diagnosed based on genes rather than
very huge liver I had 2 weeks back. Either it was either LCAD defect or a GSD.
So interesting. So Dr. Prachitji, we will definitely try and see if we can refer this patient to you.
Yes, yes, sure.
And I think it has been a very interesting discussion. I think Sabath has presented quite well.
Yes, Dr.
I think
Sarbat, you have
that is-
presented well.
yeah.
Don't worry, because we kept asking you so many questions. It's for the sake of learning. So somebody has to become the scapegoat, and that was you, unfortunately. But you have done a good job presenting. It is just we need to ask you the questions so that we get, it's a good discussion. That's all. That's all. It's not
In case presentation, scapegoat gets benefited. In life, scapegoat gets cut.
This is very true.
Case presentation,
Present.
the listeners don't get benefited. The scapegoat gets.
So I think present more and more cases.
I would also
And,
like to thank.
Yeah.
Pratichi ma'am, last moment you agreed to, fit in and become the panelist. It was so nice
No
of you
worries.
to have here. And
No worries.
yeah.
My pleasure.
Yeah, and it was really
ma'am, I'm
very
Dr. Sarita. I
informative,
spoke to you that day and it was very nice.
very nice discussion. And I think today everybody learned a lot, but I think Dr. Sabath learned a lot today. So I think, he deserves, congratulations. And I would thank Dr. Deshpande sir and Dr. Pratichi madam for guiding us through this difficult case. And on behalf of IAP Pune, I think we'll end this session here. I would like to say thanks to all the participants also. We'll see you after 2 weeks. So I'll put up the timetable again.
Yeah, thank you
Thank
so
you
much.
very
Thank you so
much.
much for
Thank you
inviting
all.
me. Yeah.
Okay. Thank you.
Bye,
Bye,
sir.
sir.
Thank you. Thank you, madam. Bye.
Bye. Bye.